This session is going to be on refractive surgery, and we've got a very nice, what we believe is a very nice program with a very distinguished faculty and a very nice panel. So we're going to be looking at topography-guided laser correction, some of the things we can do to prevent aberrations when we're doing treatments, and then the role of OCT in making decisions about refractive surgery, and then Professor Stilton's going to be speaking about managing flap and interface complications. So we're going to start off with, you can't see it here unfortunately, I don't know what happened to the slide, but it's topography-guided laser vision correction. We're going to speak a bit about the indications and then interpreting topography-guided ablations. So some of you might have been here last night at the Contour Vision launch, so some of this will overlap. But the general thinking, when you're thinking about laser refractive surgery, this is the way you think about it. If the patient, everything looked good in terms of topography, visual acuity, and visual quality, you then start making a decision about what your treatment's going to entail. And if the treatment, if you have no problems, the topography is fine, there's no problems at night, you're correcting well, then you ask yourself the question, do I want to induce any aberrations like you would with custom Q? If the answer is no, you would tend to do wavefront optimized. If the answer is yes, I'd like to because I want to do advanced monovision, then you think about doing custom Q. If there are any issues with this, the topography is not good, the vision's not good, you then start thinking about a customized solution. And that's when you look at the wavefronts. If the wavefronts are good and they're validated, you do a wavefront map, you do a wavefront guided procedure, and if they're not good, you do a topography guided procedure. Now things have changed a little bit with the advent of Contour Vision, where we're using it more and more for primary procedures, but this is still in the back of our mind about when we use it in general. So a wavefront guided ablation uses the entire eye's information to drive the treatment, and it's designed primarily to change both the lower order and the higher order aberrations, to reduce both. Topography guided ablations, unlike wavefront guided ablations, are using the corneal data to change the ablation. And as we all know, the cornea has the greatest refractive power, and as we've heard over the last couple of days, it's really the surface of the tear film that's making the difference, because that's where the rays change direction. And on many platforms, you can use both a Placido disc to drive a treatment, or you can use a Scheimpflug device. And the main aim is to regularize the cornea, and a secondary aim is to get the refraction right. So with these difficult eyes, often we'll tell a patient that it's a two-stage procedure. The first stage is regularization, the second stage is then the refractive component. We're going to try and share some ideas on how to make that predictive effect of the regularization process more accurate so that you can do it in one go. So we can get very, very colorful and impressive wavefront maps even from raw data that looks like this. But this raw data is nonsense, it's noise. This is one of the beauties of the Chernigg system. You can actually go and see where the data is coming from and whether the data is validated or not. And this is the kind of map on a wavefront procedure. When you see raw data like this, the software is giving it the all clear, but you can see that the centroids have been picked up by the software and you're going to get a decent result. Now for the times where you don't like your wavefront, which is not infrequent, you then want to think about doing a topography guided procedure. And you can either do it based on Placido or Topalizer. Both can be used. And why did they develop? What was the unmet clinical need? Well, the unmet clinical need was there were times where we knew the vision had to be improved and a wavefront wasn't going to help. So Topalizer is taken off the Placido disc. It's a tear film reflection. The camera of all these devices is right in the center. So the central information is extrapolated. It's not real. You need to bear that in mind. But it's very repeatable and auto-captured. The oculizer on the Scheimpflug device, the device captures scatter. So it doesn't see the tear film. So even in an eye where the tear film is not ideal, you can still get decent data. In fact, it's very interesting. I don't know if you're going to have time to speak about it now, but the oculizer or the Scheimpflug doesn't even see a contact lens. So sometimes when you're doing very sophisticated treatments, you can remove the epithelium, put a contact lens on with zero power, repeat the Scheimpflug, and now I have stromal surface data to guide a treatment. So it's valuable to remember that a zero power contact lens, the Scheimpflug doesn't see. There's no central scotoma. In fact, it's sampled many times, 25 or 50, And again, it's auto-capture, very repeatable. So when do you use which one? Well, sort of intuitively you think about if the issues are more peripheral, maybe the topalizer is better, and if they're central, maybe the oculizer is better. But in practice, you typically use the one that's giving you the better data. On the wave-light laser anyway, whenever we can, we prefer to use the topalizer, because the topalizer you can also control cyclorotationally on the laser, where on the oculizer we don't have that. So on the oculizer you have to manually center the patient properly to get your toricity right. The diagnostic applications, besides primary eyes, are for things like this. So this is a patient who's had a previous laser refractive surgery probably many years ago. It's a well-centered treatment, but it's a very, very small optical zone. And here you can see in the part that's centrally active, there's a very, very oblate cornea. And this patient's going to have massive complaints of spherical aberration. Here's a patient with a small optical zone, and besides being small, it's also decentered. So now you have spherical aberration and coma. And here's a patient with a much bigger optical zone, but it's decentered. So this patient's going to have coma. Sorry? Oh, okay. Thank you. Right. So, and here's a treatment that's better centered, and even though the topography looks as though it mightn't be perfect, if you look at the profile, you can see the entire optical zone as a good profile and is in fact slightly prolate, and that's what you want. And this is the kind of case where topography-guided treatments really add value. For some of these eyes, you can't get a good wavefront map, but topography can help. And if you think about it, is a patient who had a perfectly normal cornea prior to this surgery, then has a laser. The laser gives the decentered ablation, and then surely the best information to correct it is off the cornea again, because that's where the problem is. Okay. And the kind of result you want at the end of the procedure is something where you have a prolate cornea post-operatively. Okay. This is interesting where on placido disc you may have a small concern that there might be an issue. There's a small little elevation over here. We want to make sure we're not treating patients who are keratoconic, and so Scheimpflug is always very, very valuable to confirm. And here again we see, well, there's a small elevation there, but there aren't any issues on the posterior surface. Okay. All right. Then this is the kind of result we want post-operatively, a large, big optical zone with a prolate cornea within the pupil. Something else that topography-guided treatments do that other treatments don't do is they correct for something called pupil centroid shift. So we know in this particular patient, when the pupil's small, it has a certain position, X and Y coordinates from the apex of the cornea. And when the pupil's larger, it has a different position. So if you're doing a treatment based on this information, at the time of treatment, while you're treating the eye, the pupil has the ability during the laser surgery to be oscillating. And so where's it going to be centering? So this has the ability to despite the fact that there's no corneal apex fixation mark, it basically translates to that, because irrespective of what the pupil's doing, the laser knows exactly where to place the spots so that it's centered around the corneal apex. So whenever you do a wavefront optimized or a custom Q procedure, you have the choice of where you place the ablation. Is it pupil center, is it corneal apex, or is it anywhere in between? Whenever you do a topography-guided procedure, automatically it's always centered on the apex. So as Marsden Sinjab said earlier this morning, when you're doing a topography-guided procedure, you have to bear that in mind and think about that when you make your flap. So as far as topographies go, these are two very powerful diagnostic devices. They're two powerful therapeutic devices, and they integrate very well into WaveNet. So the information comes off these two devices, and we now want to go and make a decision of how to use them. So the topo-guided part is primarily to regularize the cornea, and it might also address angle kappa. This is also sometimes misunderstood. When you do a procedure that's topography guided, you have a choice of saying tilt on or tilt off. We always default to tilt off because tilt off uses way less tissue, and tilt off does not correct for angle kappa. Tilt on does, but using tilt on uses much, much more tissue. So most times we're taking it into account when we do the ablation, but post-operatively you don't see a big change in angle kappa. So we want to improve the corneal shape and treat the residual refractive error. So when you're starting out with this, sometimes a good idea is to tell the patient this is going to be 2 stages. Number 1 is no refractive power, regularize the cornea, wait 6 months to do the second part. As time goes on though, when you start doing this, you might make a note on your chart. I'm doing the 0 power topography guided part today. I've looked at the ablation and I'm making a prediction today. This is going to make the patient 1 diopter more myopic. And then in 6 months' time, you look at your prediction. Did it come true? And with experience, you're going to start finding, I'm getting this right all the time. And once you're at that stage, you can do it at the same time. Why wouldn't you do the 2 at the same time? And the idea of this is to try and give you some ideas of how you could do that, to do it as a one-term procedure. So using topolizer versus oculizer, they're not very big differences. We've published this before. Sorry, I don't know why this has come up again, sorry. So you take 8 maps. So one of the things about 8 maps is you've really got validated data. You can validate them on the laser to make sure they're right. And now, if you can predict the refractive effect of the topography changing component, you can increase your refractive predictability. There are 5 methods we use. I'm going to speak, one's very unique to wavelengths. I'm going to speak about the 4 that we can use anywhere. So the one thing you can do, which will never get you into big trouble, is if you do a number of wavefront maps and you don't get 4 that are good, but you know there's at least 1 or 2 that are good, the data is valid, but it's not enough to drive the treatment. You can look at what the wavefront guided ablation is going to be. And say for argument's sake it's 100 micron. You can then load the topography guided treatment and adjust the refraction until your ablation depth is also 100 micron. And then you know your refractive component is the same as a wavefront, which includes everything, but your higher order aberrations are coming from the topography guided treatment. So that's a nice way of doing things. And here's a patient with an optimized that's going to be using, you can see the ablation profile there for +1, -150. And this is what the topography guided looks like. This is what the wavefront guided looks like. And they all look quite similar. The ablation depth is quite similar. Right, the second thing you can do is what we did yesterday in the Contour course, is look at the high order ablation profile and make a decision about how this is going to change your refraction. So what is the shape of this higher order ablation profile and what is the magnitude? And just to remind you, the higher order ablation profile, this is the total correction on this topo-guided procedure. You've entered the topography and you've entered the refraction. If you then go and make the refraction 0, you then see the higher order ablation profile. On a case like this, you're going to try and work out what the refractive power of this is going to be. So this is just the topography component. So we haven't finished this. So what we do here is we look at what the treatment in the center is. It's 3 microns. What's the treatment? This is a hyperopic shape, first of all. It's a hyperopic shape. It's going to induce myopia. And the center is 3 microns. The periphery is in the order of about, the average there is between 9 and 6, so probably around about 7 microns. That's a 4 micron differential. 4 microns equates to a quarter of a diopter. So if this patient was being treated for -1, you would now treat them for -1 1/4. The next thing you can do is have a look and see what does the software suggest. So often, the software will suggest something. And again, you've entered 0, but the topography says there's a -1 over there. And very, very frequently, that number corresponds. We don't know exactly what it is, and the company don't disclose what it is, but too frequently it corresponds to the adjustment that you want to make. So it almost seems to be the refractive component of the topography-guided procedure. And then something that David Lynn designed a long time ago, which is very helpful too, is this process. It's called TNT, Topography Neutralization Technique. So what do we do here? There are 4 steps. He's going to put a 0 treatment in. He's going to have a look and see what he needs to do to the cylinder to negate this. This is a point that only David can do. No one else can really do it. This part everybody can do, is how you use the sphere to negate. And let me show you how it works. So here's our 0 power treatment. And David then does some adjustment to the cylinder to make this more regular. As I say, I haven't been able to reproduce it. But now, on the sphere part, you now start adding sphere to make this look like a PTK. So we know a PTK has no refractive effect. So if you have this initial shape, top left, that's going to have a refractive effect. So if we start adding minus sphere, how much minus do we need to add to make this look as close as possible to a PTK? And that amount is the refractive effect of that correction. And then you just make the adjustment. So, right, topography guided procedures can be primary or secondary. Primary is Contura. I'm going to go through this very quickly because we did this yesterday. Contura is specifically TCAT for first-time treatments, and the objective is to meet the refractive target. So prior to doing it, you would enter your nomogram adjusted input, wherever it comes from, and now this is what we want to treat, minus 675. That's what we need to enter. So that gets entered into the laser, and off the topography, we now have information that is on the screen. We now enter that as 0. Whatever we see, the pattern over there has a refractive component, sphere and cylinder. The basics of sphere is that one diopter corrects, or 15 microns are needed to correct one diopter. So we're going to make an adjustment now based on our higher order ablation profile. There's our preoperative topography. This is the ablation profile that's come up with a 0 correction. It's got a hyperopic profile. The steepest point on the periphery is at 8 microns. The lowest point in the periphery is at 6 microns. The average is somewhere over there, whatever it might be. The center is 3.75. And that difference, what is in the periphery, what's in the center, is 2.85 microns. That as a fraction of 15 is 0.19. That correction right there is going to make the patient 0.19 more myopic. So program that in and you can do it. As far as cylinder goes, the patient's cylinder that they seek is a combination of their astigmatism and coma. So you add the Fourier analysis now to your treatment, your planning. And the Fourier analysis, that's the spherical component. This is the astigmatic component. This is the higher order irregularity, and this is the decentration or coma. You now place a line on your topographic axis. You take that same axis and place it over the decentration. If there's a very good correlation, then you can make an adjustment where you look at the difference from one end to the other, and in this case it's half a diopter. You divide by 2, and this allows you to work out what to do in terms of sphere. This is all arbitrary for now. This is going to be far more sophisticated in time as more and more people use this and make it easier. But this has worked well. The adjustments we make tend to be small, and so even if you don't make any adjustment, you're going to get a good result. But when you start refining it more, you get better results. So increasing predictability, what's going to help is if you see higher order ablation profiles that are more than 10 microns, maybe initially discard them and rather use the cases that are easier and compare the difference in what you're doing in the center versus what you're doing in the periphery. So if you're looking at an optimized procedure versus a customized, in principle, to correct one diopter, we have to do 15 microns in the middle and nothing at the sides. This ablation over here, which might be a customized ablation, is 15 microns at the side, 30 in the middle, but the refractive effect is still one diopter because of the differential, even though the ablation depth is double. Now, Marsden touched on this morning. What happens when you start adjusting the optical zone size? So if you look at this patient over here, this is a -1 at 6.5, and it's the normal 15. This is making the optical zone size smaller, and you use way less tissue. This is making it bigger, and you use a lot more tissue. So if you look at an optical zone size for a -1 correction, there it is for the 15 for 6.5. It's at 9 for 5. It's at 23. There's a massive variation. So the optical zone size is important when you make these calculations. If you make this treatment for -5, you can now see that the difference in ablation is even more significant. It's much more significant. So if you look at the ablation depth across an arbitrary 100 measure versus a measure which is this size, you'll get to the point where you're doing 5 at 100, but you're doing 18 when you're doing the slightly bigger zone. So you've gone and increased the optical zone by a factor of 1.85, but you've increased the ablation depth by 3.6. So when you do see these high order ablation profiles, you've also got to try and bear in mind if everything's concentrated centrally, it's going to have a much bigger effect, and just bear that in mind when you make the adjustments. I'm going to show you one example of a secondary procedure. So this is a procedure for a patient. In fact, you know what? I want to go to this case over here. So this is where we really enjoy using topography-guided treatments. This is a patient who had a flap complication in a different center. They fortunately decided not to treat the first eye, the right eye. It was a -175. The left eye was pretty much the same. And this was the result that they achieved following the surgery. And what the surgeon had done, this was the preoperative on the right eye. This is what I found presenting on the left eye. What the surgeon had done was they got a decentered flap and decided for whatever reason to continue with the ablation. Did the ablation, then got really nervous during the procedure when they realized that a lot of the ablation was on the surface of the eye rather than under the flap, and put the flap back, and the flap didn't settle down well, and they just lost confidence and wanted to get rid of the patient. So they sent the patient on. When we first saw the patient, we could see the pupil sort of hemidissected with steeper cornea on the one side than the other, and the flap was also full of striae. So the first thing we did was to resuture the flap and just stretch the flap out. And that already, in a very short space of time, already started showing improvements in terms of the topography and the best corrected acuity. And at 3 weeks post-suturing, we waited for 8 weeks, and at 8 weeks, once things had settled down, epithelium had time to settle, we could see what the error was that we wanted to correct with topography guided. Right. So the next step then was, I told this patient, because of the irregularity, I'm going to do this in 2 stages. And the first step is going to be the regularization. We'll wait for 6 months, and the second part will then be just the refractive correction. So we decided in these cases, especially if the patient knows it's 2 stages, it lends itself to doing the topography-guided treatment as a trans-epi procedure. So the first thing you do is you simply do the PTK. And as you do the PTK, you saw yesterday, as you're going down, you'll already start regularizing the cornea. And then as the second part, directly after, you do the topo-guided PRK. And this is how the patient looked 3 months following it. And he was at 6.5, correcting to 6.5 at -125. And you can see how much better this looks. And all we've done is just the regularization procedure. He's at 6.5. And once we got his 6 months, he was looking like this. And at the moment now, he's correcting to 6.5. His uncorrected vision is 6/10. And this is what the cornea looks like. And his next step now is to do the enhancement. But he's got to the point where he's saying, I'm actually very happy with what I'm seeing. I don't know if I'm going to do the enhancement. If you do go ahead and do the enhancement, how would you do it now? Would you do it wavefront optimized, wavefront guided, or topography guided? I think topography guided is not necessary. We now need refractive accuracy. So we'll probably look at doing it wavefront optimized or wavefront guided. So in summary, as far as topography guided treatments go, it's a very, very powerful tool. It's giving us phenomenal results in primary treatments, contour vision. We saw the FDA results yesterday from Professor Stilton. This is the first time we're showing patients you can see better after surgery without glasses than you did before with your best correction. And it's a wonderful repair tool. So I encourage you all to get involved with topo-guided surgery. Thank you very much.
Thank you, Dr. Arthur Cummings, for the great presentation. So we'll proceed, and the second presentation will be continuation, in fact, and will be done by Dr. Arthur Cummings, how to avoid the induction of aberration during refractive surgery.
Thank you very much. So one of the beauties of the technologies we have is we see what they can do, they're powerful, but sometimes it works against us too, because it makes us less diligent with what we're doing as we're going along. So one of the best ways to get great results is to avoid complications in the first place. So how do we avoid them? So this is important with refractive surgery. The lower order aberrations remain key. A patient coming into you for a correction of vision wants to see well afterwards. And a patient with minus 0.75 of myopia with very, very small higher order errors is more symptomatic than a patient who's plano but who has high order errors. So the number one target, that's why it's called refractive surgery, is to get the target right. So we want to get that right. And so there are ways we've seen how to make it more accurate. So high order ablations, the two most common ones that we can induce are spherical aberration and coma. Coma is normally introduced by decentered ablations, and spherical aberrations are normally induced by small optical zones or doing very, very big corrections, or treating corneas that land up too steep. All right, so coma, mainly caused by poor alignment under the eye tracker. And that's one of the biggest mistakes we make with modern lasers, is we believe because the trackers are so good that we don't have to pay attention to detail. But the bottom line is they don't compensate for everything. So we've got to take a few things, we need to make sure of a few things before we start. Number one, make sure that under the laser, when you put the crosshairs across, that the two eyes are at the same height. The patient's not decentered or rotated. The second thing you want to do is when the patient's lying down is not to cross their legs. Often when their legs are crossed, they're bouncing their leg and their eye's moving around too. Additionally, occlude the second eye that you're fixing with the eye that's being treated, and crucially, ensure that the eye is perpendicular to the laser beam. So if you think of a patient looking at a laser source, and if they're looking at the light, they're looking directly at the fixation light, that laser beam is going to be placed, it's aimed at the pupil, but it's going to land up on the cornea at the right position. So that's well-centered ablation. As opposed to a patient who's looking away from the target. They're looking away, the laser is aiming at the pupil, that's what it should do, but look at your centration. You've suddenly decentered your treatment, despite the fact that you've got a modern laser. So you still have to be aware of the fact that you've got to make sure the patient's looking in the right place. So the laser we use, and most lasers, would have the fixation light, which is normally something blinking in the middle, and there are also lights around this that help with additional orientation. And either they are specifically there, like the wave light has, they're called NeuroTrack, or they're simply your lights that you use for illumination, that many other lasers have. So what you want to do is you want to ask the patient, you can see the green blinking light, is the green light in the center of the four lights, or is it slightly decentered? If the green light is not in the center of the other lights, reposition so that you know the patient is perpendicular to the line of the treatment. We spoke about this a moment ago. Where are we going to center the ablation? Is it pupil center? Is it corneal apex? Somewhere in between. I think most people sort of think for an optimized treatment, a very regular, rotationally symmetric treatment, it's not that key exactly where you place the treatment. But the moment you start doing treatments that include higher order aberrations, then it's mostly best to center on the corneal apex. And that's why with a topo-guided procedure, it automatically goes there. And with a wavefront guided procedure, it's always going to use the pupil as the reference, but it's going to place the treatment wherever it needs to be relative to the reference. So I spoke to a number of the companies to ask them what are they doing to help us along this track of not inducing aberrations. So this came from Charlie Campbell, who works for Physics at the Wavefront Congress. He presented this, and he said for the main treatment, the main objective from their point is not to put treatments in the wrong position. And as far as they're concerned, the biggest two issues are the rotation error on astigmatic patients and the change in ablation rate as you go down, as you go deeper into the cornea. And this is why you've seen a number of the laser companies in the last number of years become faster and faster and faster, and saying speed is important. And I think it's right, because when you're working on a much slower laser, there's more time for dehydration to occur. Where when it's a faster treatment, it has less effect. I put this on, I've placed it onto this, it hasn't blocked these slides out. I'm really sorry, I don't want these slides included. There's too much detail here. The other point here, as far as Physics are concerned, the thing they really concerned about in terms of rotation is just the astigmatism, not really anything else. I'm really sorry about this. This was taken out. I then spoke to these people from these companies, and grateful thanks to them for giving us their input. Oh my goodness. So Wavelight started this whole process of reducing aberrations by doing the optimized profile. We all know what that is, and all of the companies are using the same thing now. I'm sorry, this was not included in my talk. I took it out. Schwint have been very careful about the way they've thought through this. They've added a lot to what they're doing. So one of the first things they do, if you do a procedure on a wave light that's wavefront optimized, The laser doesn't care if the cornea is 49 or 40. It does the same ablation. On the same laser, if you do it custom Q or you do it topography guided, now the laser does care. It changes the ablation profile to suit not only the Ks, but also the asphericity. So it really customizes it. Schwinn do this on all of their treatments. They compensate for the spherical aberration and focus shift based on the Ks. They have a different aspherical compensation as a function of the optical zone. So it's not a standard one. Depending on your optical zone, they'll have a different induced spherical aberration compensation. They have an asymmetric offset to compensate for the visual axis. They have a dehydration module that, as the treatment progresses, depending on the time, they'll change the ablation to suit what they anticipate is happening with dehydration. They've got a corneal and corneal flap thickness compensation. So if you tell the laser you're doing a 100 micron flap versus a 140, the ablation will be slightly different because they know you're working at a different level in the cornea. And there are different ablations for femto LASIK versus LASIK versus PRK or trans-PRK. And there's an automatic dynamic transition zone calculation. So, and there's also an adjustment for age. So things have really progressed from the manufacturer's point of view about how to make the outcomes better. Zeiss, the point I wanted to tell you about Zeiss, didn't highlight it here. But anyway, what Zeiss said is all they've been doing, they can't tell you exactly what they've done, but they've done incremental improvements as time has gone on. Physics we spoke about, and B&L have said basically the same thing. They had this ablation aspheric profile introduced in 2006, and even in their latest treatment in the Tenio, they're still using the same basic aspheric correction. So moving on to customized ablations. This is a different topic which we've discussed already. So I think, for me, that's as far as we can go to reduce aberrations. Number one is attention to detail, irrespective of how sophisticated your laser is. Pay attention to detail, make sure the patient's well aligned, and do your procedure as accurately as you can. And something else you need to do is, I've got something I've used in the practice for a long time. I did a retinal fellowship, so I've done a lot of retinal surgery in my life. And the person who told me that LASIK was easy and retinal surgery was very difficult was never the right patient for my refractive practice. I wanted someone thinking about every LASIK procedure as being just as challenging as the most challenging retina. Because at the end of the day, you're treating a patient who's economically active, healthy, sees well with their glasses and contact lenses, and you're looking for a solution that's going to be at least as good with zero complications. So I think you need that same kind of attitude to refractive surgery. You're simply not open to having complications. So thank you for your attention. Thanks very much.
Assalamu alaikum. I will share with you the role of anterior OCT in refractive surgery. In some cases, you will see the images of some cases. Actually, I use the anterior OCT in the diagnosis and treatment. I use it to diagnose some corneal lesions, to diagnose LASIK flap complications, double anterior chamber after lamellar keratoplasty, in keratoconus detection, and in keratoglobus diagnosis, and in glaucoma diagnosis. In addition, it can be used in to guide the PTK and for LASIK planning in some cases, and to do follow-up after corneal cross-linking. Starting with the diagnosis, the OCT, the anterior OCT, is very important in diagnosing some corneal lesions. As you see, this is subbowman opacifications. It can show you where it is localized, what is the depth of it, and what is the thickness of it. And this is another picture of the same patient. It also helps in diagnosing Salzmann nodular degeneration and guiding the treatment, as we will see later. It shows the location and the relationship with the structure of the cornea and the depth of it. This is the corneal thickness map given by the OCT. We can see the thickening of the cornea in the location of the Salzmann nodular degeneration. In LASIK flap complications, the most, let us say, common LASIK flap complications are infectious keratitis, diffuse lamellar keratitis, DLK, pressure-induced stromal keratopathy, PISC, central toxic keratopathy, CTK, and epithelial ingrowth. Now, this is the OCT of a normal cornea after LASIK. Let us say there is no inflammation, the interface is healed, and you see the integrity of the cornea. Now, we can use the anterior OCT to differentiate between diffuse lamellar keratitis and pressure-induced stromal keratopathy because clinically they are very similar. As you see, this is a case of pressure-induced. It may give the appearance of DLK. As you see, the slit lamp view for both DLK and PISC, it is almost similar, but when we do the OCT, you can see a gap under the flap and retention of fluid. This is why the doctor and the patient go into this problem, because it gives the appearance of DLK, and the doctor will start steroids, increasing the steroids, and it worsens with steroids because it elevates the intraocular pressure, and the intraocular pressure will increase the fluids within the stroma and under the flap, and this will lead to a spongy structure of the cornea and will lead to false low IOP measurements, and this will increase the problem more and more. Doing OCT will solve the problem, as you see. In addition to some clinical clues, the DLK, this appearance of the DLK usually comes within the first 24 hours, while the PISC comes in the same picture but after 1 week, and the DLK usually responds to steroids, while in the PISC, the steroids worsen the problem, worsen the appearance. The OCT can be used also to differentiate between diffuse lamellar keratitis and the central toxic keratopathy, because you may see this a presentation in both, in central toxic and in DLK, especially in the DLK stage 4. The differentiation can be done by the OCT. In the CTK, we can see central opacification with full depth, while in the DLK, I'm sorry, I don't have the picture for DLK in this case. The DLK shows an opacity, diffuse opacity, but more centralized and not full thickness in the cornea. It is just in the interface. So by the OCT, you can differentiate between these two entities, and in addition to some clinical clues. In DLK stage 4, it comes after a week, while the CTK comes from the first couple of days, and in DLK we can see diffuse with central accumulation of the opacity, while in the CTK it is only central, and DLK usually responds to steroids, and while the CTK does not respond to steroids, and maybe the best to do is to observe the patient. Of course, we will listen to Professor Doyle later about management of such complications. The OCT as well can diagnose melting in cases of DLK, because DLK in stage 3 may proceed to melting or may proceed to stage 4, as we saw. Melting can be diagnosed by the OCT. As you see, there is a gap, but this gap is not fluid. It is dead tissue, as you see here. There is dead tissue, fibrinous exudate under the flap. And this is the corneal pachymetry map by the OCT. We find thickening with irregularity. The epithelial ingrowth, the OCT has a very important role in diagnosing, not the epithelial ingrowth, of course it is very apparent on the slit lamp, but it is very important to diagnose from where, or the tunnel, or the hand feeding the nests. It can show you the tunnel through which the epithelium is feeding the nests, and it can show you the gap or the defect in Bowman layer through which the epithelium is going under the flap. And this is very important in the treatment because the epithelium nests cannot survive without feeding epithelium coming from out or from the bed out of the flap. So if we cut this tunnel, if we cut this hand feeding the nests, we can treat properly the epithelial ingrowth. Otherwise, you may have recurrence of such cases. So we have to define where is the edge, and this can be better done by the OCT. The double anterior chamber can be diagnosed as well, especially when the cornea is edematous. You cannot see the double anterior chamber on the slit lamp. In this case, you can see it on the OCT, and you can see also where the defect in decimate membrane. In keratoconus detection by the epithelial mapping, the epithelial mapping can show a thinning of the epithelium over the apex of the cornea, which may precede even thinning of the cornea itself or the bulging of the cornea. So it might be the earliest, let us say, objective sign on the cornea before other topographic, let us say, other topographic features may appear. In addition, it may give you some indices which may indicate abnormality in the cornea. In keratoglobus, you can see the diseased cornea. It is not only generalized thinning, but it is irregular thinning. As you see, it is very diseased cornea and can be seen on the OCT. This is keratoglobus. And finally, in glaucoma, because it gives measurements to the angle and it gives measurements to the anterior chamber. Now, regarding the treatment, OCT can be used in guiding the PTK because it shows you where the opacity is, and according to that, you can take a decision. For example, if it is deep opacity, you have to go for keratoplasty, and if it is above Bowman, as in Salzman nodular degeneration, just go for peeling, and if it is superficial opacity, you can do PTK. And it can tell you what is the depth of treatment and is it possible or not, because if the opacity is deep enough, you may not be able to do it by PTK. You may do anterior lamellar keratoplasty. For LASIK enhancement, usually I do LASIK enhancement by PRK. So I'm going to work to do PRK over the flap. Now, the best way to evaluate the anterior corneal surface, in this case, apart from topography, of course, topography, Placido, not tomography, apart from Placido, OCT can give you the structure of the anterior part of the cornea, and it can tell you whether there are irregularities, what is the thickness of the epithelium, and you can decide according to that. Follow-up of cross-linking, we all know about the demarcation line separating between the anterior cross-linked and posterior less cross-linked structure of the cornea. However, if you don't see the demarcation line, it does not mean that the cross-linking is not working. The presence of demarcation line means that it is working, but the absence does not mean that it is not working. But it is good for follow-up. For the phakic IOL, it's important to do the measurements for the anterior chamber, especially, let me say, in general, OCT is better than the Scheimpflug, especially when we have small opacities or haze in the cornea, because the Scheimpflug images will not give us very correct information, because it depends on blue light, and while the OCT uses wavelength, which is much better. After implantation of the ICL or the, let me say the anterior chamber or posterior chamber phakic IOLs, it is very helpful tool to evaluate the implantation, whether it is tilted or not, what is the volt, if any touch with the lens, and so on. Thank you very much.
Thank you. We're going to speak this morning about LASIK flap interface complications, not dislocations, miscreated flaps and things like that, but the postoperative things that we see at the interface. So let me begin by discussing diffuse lamellar keratitis. The original description was that of Smith and Maloney in 1998, 13 eyes of 12 patients, with findings occurring 2 to 6 days after primary or enhancement LASIK. The original description was one of diffuse infiltrates with or without scattered faint local foci, no anterior posterior extension, intact epithelium, no anterior chamber reaction. Presumed non-infectious with negative cultures when they were obtained. When we began to do LASIK in 1994, we did not experience DLK. In fact, we stopped tracking it because they were so rare in 1999. Our percentage of actual cases with DLK during those first years was 0.13%. Then we noticed a cluster of DLK in December of 2000, up to 1.87%, or 17 out of 909 that month. So we began to review our procedures to see what had changed. And the thing that we noticed was that we had changed our sterilizers. We had gone from a Tuttenauer to a Statum. So we believed that the Statum was part of the problem, perhaps the production of biofilm with contamination of the water reservoir, with endotoxin-stimulated interface inflammation as the etiology of DLK. And so we installed a new sterilizer. And we looked retrospectively to look at the incidence of DLK and predictive factors. For this study, we defined DLK as a diffuse inflammatory infiltrate between the flap and the stromal bed, which was out of proportion to epithelial defects or interface blood when present. Our study population included 61 eyes out of 15,119 procedures in 7,000 patients. The onset was typically early, diagnosis within 2 days. Usually it was peripheral white cells under the flap, sometimes centrally, sometimes a dense central aggregation in 3 eyes. Cultures were negative in 4 of the 11 initial cases where we weren't sure what was being observed. So we took a look at multiple procedures in the same eyes, 13 after primary, but none after enhancement in the same eye. So we believe that DLK was not due to an individual sensitivity or to material related to LASIK. Bilateral with LASIK with unilateral DLK occurred in 28 eyes, first eye in 15, second eye in 13. So we believe that DLK could not always be caused by material deposited by the microkeratome, because of the second eye should not be involved if the first eye was not. Primary versus enhancements, most of them were primary. We saw them in enhancements as well. So we ruled out the possibility that the microkeratome might be the only etiology of DLK. We took a look at the influence of the sterilizer. Here is the incidence before with the Tuttenauer and after with the Steris. And during the period that we had the Statum, the incidence was clearly higher. We thought that if the sterilizer was responsible, the increased incidence should be to do DLK after primary procedures and not enhancements. These are our incidents after primary and enhancements. And you can see during the period that we used the sterilizer, indeed, primary procedures created more DLK. So we conclude that DLK is a nonspecific inflammatory response to multiple stimuli. The LASIK flap interface is involved because it's easy access to white blood cells. There can be sporadic and clustered occurrence, as we observed. Sterilizers with reservoirs can be responsible for epidemic cases of DLK, such as the ones we experienced. There are a number of other reported causes of DLK: epithelial defects, microkeratome, oil debris, etc. In even atopy, I'm not sure this is a legitimate, statistically significant correlation. Treatment, topical steroids if the diagnosis is obvious and inflammation is mild. Lift the flap and irrigate it if it is severe to help remove the inciting material. Culture and begin antibiotics if diagnosis is questionable. The key is understanding when we are dealing with DLK and when we're dealing with something else. Eric Leinberger has published a staging criteria, which is shown here. The treatment recommended is shown here, basically steroids for mild involvement, lift and irrigate for severe. And the right lower image, stage 4, which is sometimes called toxic keratopathy, is difficult to treat and reverse. The key is differential diagnosis. This is mycobacteria. Another case of mycobacteria. Candida. Gram-positive cocci. This one is DLK. There is no D in infectious keratitis. If you notice those images that I showed you, none of them were diffuse. That is the best tip-off in diagnosis at the slit lamp. So suspect infectious keratitis in cases that are not typical. Localized infiltrates distinguish them from DLK when there's no D in DLK. They may appear later than 2 days, which is common for DLK, and they may worsen after an initial response to steroids. Some people talk about late diffuse lamellar keratitis. This is a diffuse interface inflammatory infiltrate that appears a week or more after LASIK. It's associated with an inflammatory stimulus, usually that can be identified: epithelial debridement, iritis, corneal erosions, infectious and non-infectious keratitis. It's a result of inflammatory infiltrates due to another stimulus. Once again, they appear in the infiltrate because of easy access. One other entity that we need to think about is pressure-induced stromal keratitis, one that Mason just recently described. It consists of fluid in the LASIK flap interface, associated stromal haze. It is due to an increased intraocular pressure and may have a paradoxically low measurement because the cornea is easy to indent with a fluid cleft. It's often caused by steroid-induced pressure elevation in eyes that have been treated with steroids for what was thought to be DLK. It should be relatively easy to distinguish these two entities. DLK occurs early, PISC occurs late. DLK looks like white cells. They are punctate, tan-appearing opacities. PISC looks like corneal edema. It is a diffuse, white ground glass appearance. A good observer at the slit lamp can tell the difference between white cells and corneal edema. And a good observer can see the fluid cleft that can be illustrated by OCT. In fact, I've never seen a case of PISC that you could not diagnose at the slit lamp. You can see what the OCT will show you. You just have to be a good observer. PISC is late. There is no inflammatory stimulus. Fluid cleft is visible. Edema is present, not a white cell infiltrate. The pressure may be increased or falsely low. You can get a better idea about the pressure by using the tonopin at the limbus or using finger tension. As a cornea specialist over the years, I've trained myself to routinely press on the eye and observe the indentation at the slit lamp. This gives me the ability to measure and estimate the intraocular pressure, usually within about 5 millimeters of mercury. Eyes with PISC have an obvious difference between the measured intraocular pressure centrally in the cornea and the finger tension that you observed. I propose nomenclature as follows. DLK is early, characterized by interface inflammation. There is no recognizable inflammatory stimulus. For example, epithelial defect, blood in the interface. Secondary interface inflammation can occur early or late. There is a recognizable inflammatory stimulus, such as an epithelial defect or blood in the interface early on. Another recognizable source of inflammation late, for example, a traumatic epithelial defect, a corneal ulcer. PISC is a bad name. It isn't keratitis because it doesn't result from inflammation. It should be called keratopathy, pressure-induced stromal keratopathy. It is an initis. So this is my recommended nomenclature to help us communicate and also to help us think about the pathogenesis of these entities that we may see after LASIK. Understanding the pathogenesis is certainly the key to successful treatment. Thank you.